So today we'll be talking about dementias. But before we start, I know that I'm giving you a picture of an MRI brain. Sorry. Can you hear me now? Okay. So I know we're talking about dementias, and the reason why I'm showing you an MRI brain is for you to have a small interpretation now, and then sort of later on during the course of today, sort of you'll know why we are sort of showing you this MRI. But before we start, can anyone tell me which sequence am I looking at here?
Like is this a transverse?
No, it's not a transverse, and transverse is not a term in MRI.
T1?
No. So what does that leave you with?
T2.
Yes. So when you're describing MRI, you always start off with what you see in front of you, and transverse is not a slice that you see through the brain. So I think what you mean is axial. So there's axial, coronal, and sagittal. This one's an axial T2 MRI flare sequence. So was it Ray that said T1? So you're actually pretty close, because in T2, you would expect the ventricles to be hyper intense. Is that right? Or hyperdense?
That's right, yeah.
Yeah. So in flare, the CSF is actually attenuated. So the signal that you get from the CSF is attenuated. And can you see my mouse here?
Yeah.
So the reason why we want to flare is because we don't want the CSF to obscure the white or the hyper intensities that I see here. So I know this is not probably from CSF, it's probably sort of from other edemas. Okay, so we'll go back to this picture later on during the talk, but just keep it in your mind. Okay, so dementias. Can anyone tell me what you guys know about dementias? Progressive disease, yeah, very good. Let me just get a whiteboard up. I forgot how to do that. Here. Can anyone see this? Yes? Are you guys seeing a whiteboard?
Yep.
Okay. I actually can't see your screen, so just shout out if you have any questions. So, dementias. Let me try and get the chat onto the other screen so that I can see it. Okay, I can see the chat now, so if you have any questions, you can ask in the chat too. So, dementias, progressive disease. Anyone can tell me any more?
I guess it commonly affects the elderly.
Yeah, commonly affects the elderly. Anything else?
There's different types.
Yeah, what types do you know?
So there's Alzheimer's, there's vascular, there's Lewy body, and also Parkinson's dementia, and everything.
Yeah, so Parkinson's dementia is more sort of dementia secondary to the Lewy body formation. And one concept that I will teach you today is that they actually hunt in packs. So in MD1 with the STI lectures, the lecturer always says the STIs usually hunt in packs. And same with the dementia or the neurocognitive diseases, they always hunt in packs with sort of psychiatric conditions such as depression, bipolar disease, schizophrenia. So you can see in elderly people with depression can usually have Alzheimer's disease or Parkinson's disease. So on a global scale, they do sort of overlap a bit. So in today's talk, I'll probably cover a few of the most common types. So I'll talk to you about Alzheimer's disease, which is the majority of the dementias that you get. It's probably around 60 to 80% as a rough figure. And then vascular dementia secondarily. And thirdly, I'll talk to you about frontal temporal dementias. Normal pressure hydrocephalus, CJD, Creutzfeldt-Jakob disease, and Lewy body dementia. Okay, so that's a general overview of what we're going to cover today. Any questions so far? So let's talk about the risk factors for dementia. Anyone? So yeah, go on.
Yeah. So things like family history, age, genetics could also be a thing, for example, in Alzheimer's. And I think it sort of also depends on the type of dementia as well. So for vascular dementia, you get all your vascular risk factors. And I believe for Alzheimer's, female is a risk factor.
Yeah, so family histories do take into sort of account when we're talking about prevalence, and you're right in that female genders is a predisposing factor. But sort of I'm more thinking about sort of overall rather than the prevalence. So I think about the causes of the dementia. So being female and sort of family history, they do predispose. But I just have a more systemic approach into thinking about my dementia risk factors. So I have an acronym for it. Not sure if you guys heard it before. So dementias, so D for neurodegenerative diseases. Oh yeah, and Alex, if you can record, that would be great. Endocrine, metabolic, exogenous. So that can be your exogenous insult. For example, trauma, for example, toxic material, radiation, blah, blah, blah. Neoplasm, trauma, infection, affective disorders. So these are like your depression, your major depressive episodes, your bipolar diseases all fit under affective disorders. So they can be a risk factor themselves for developing dementias such as Alzheimer's disease. And the last one is stroke. Okay. All right. So probably give a new page and we'll start talking about Alzheimer's disease. Oh, by the way, I'll just give you guys a link for those of you. Yeah, Alex, if you could put a link of TFI website on the group chat, that would be good, so that people know where to register and stuff. Alzheimer's disease. So what are the presentations? Usually amnesia. And it's usually the distant memories that are intact and the newly formed memories which are not the best. Does anyone know a medical term for that?
Are you referring to anterograde versus retrograde?
Yeah, but there's a slight caveat to that, in that anterograde is more inability to form new memories, Although a lot of people describe Alzheimer's disease as having anterograde amnesia, it's more short-term retrograde memory loss. So just keep that in mind. And visual spatial defects. They can also get language deficits. And remember when we talked about affective disorders, they can be risk factors to Alzheimer's disease. They can also be a complication of Alzheimer's disease. So they can get agitations, they can get depressive episodes that are significant enough to be diagnosed as major depression under the DSM-5. So those are the sort of the key clinical features to look out for a person with Alzheimer's disease. And usually people have a description of sort of a mild memory loss, a mild language deficit, mild visual spatial defects, sort of 10 years or even 15 years before it's sort of progressively getting worse. So that's your mild cognitive impairment, which may precede AD by 10 years. So does anyone know how we diagnose Alzheimer's disease?
Just taking a bit of a guess, I think it's clinically. I'm not sure whether you would see any major changes on a CT brain.
Yeah, very good. So you can actually see changes. However, you're very correct in saying that it's a clinical diagnosis, and it's actually a diagnosis of exclusion. So the things that you might see on a CT brain can be sort of atrophy of the parenchyma, enlarged ventricles. You can sometimes see signal changes as a result of plaque or neurofibrillary tangles, as sort of your abnormal intensity showing up around the parenchyma of the brain. So you can see that. However, if a person has none of that, you can still diagnose Alzheimer's disease by diagnosis of exclusion, despite the absence of findings. So you can only get a definitive diagnosis at autopsy after the patient sort of dies. And that's your definitive diagnosis. So just remember that it's a clinical diagnosis and it's a diagnosis of exclusion. And it's based on a cognitive decline. With or without, okay, I gave it away. Without sort of motor impairment. Okay, so if there is motor impairment, then I'm thinking about other differentials, for example, vascular dementia, for example, frontal temporal dementia, or MPH. So the differentials to consider, or to rule out first before Alzheimer's, which are important. First of all is your vascular dementia. Second of all is your MPH. And your chronic subdural impairment. Okay. And you can sometimes use a mini mental state examination to sort of pick up the neurocognitive declines in your patient. And usually it's a trend rather than a sort of a specific test. So you do want to bring your patients back, and usually you get a referral from GP saying that, okay, the mini mental state examination has declined in score. Sort of they're worried about Alzheimer's disease to be managed by a specialist. And remember with the risk factors, we talked about metabolic stuff. So what are some other things to rule out metabolically? before diagnosing Alzheimer's disease. So, for example, a patient comes in with fatigue, generalized fatigue, weight gain, memory loss, headaches, stuff like that. What would you want to rule out metabolically?
The glucose, low glucose.
Nope.
This isn't metabolic for the next one, but I think hypothyroidism.
Yeah, very good. So thyroid is always a consideration. Sorry about that. And also your vitamin B12. Neuro. Okay. And that's pretty much it about diagnosis. And we'll probably move on to treatment.
Just a quick question. Would you be able to explain why hypothyroidism could potentially present with those symptoms?
Which symptoms specifically?
So why would it be considered to be a differential diagnosis in this case?
Yeah, very good question. So hypothyroidism, usually patients can be obtunded. They can have slight confusions as well as that they're metabolically slowed. So remember when we talked about sort of your visual spatial defects and your language deficits. So if a person is sort of confused and motorly challenged by sort of your slow metabolism, you can have a similar sort of clinical presentation of sort of a person being really fatigued, not being able to maneuver around the house, decline in sort of expression of language, and sort of memory concerns. As well is a presentation of hypothyroidism too. They can present with headaches, weight gain, heat, cold intolerance, and stuff like that. However, the timeline, the time course can be a little bit different to your classic Alzheimer's disease presentation, but it is a test that GPs will conduct before sort of sending the patient to a specialist because of that similar presentation. Does that answer your question?
Yeah, that's great. Also following up, just with regards to differentials, how would you differentiate between Alzheimer's disease and just the normal aging process with elderly people forgetting bits and pieces?
Yeah, very good. So usually it's based on objective testing. So neuropsychological testing can help with that. So usually with aging process, despite them aging, they usually have a pretty good cognitive status up until when they're terminally ill and they have sort of a lack of consciousness or lack of attention. So in your sort of mini mental state examination, which is a test out of 30, you can look it up the components. If you see that there is a progressive decline in scores, then you would be worried about sort of your Alzheimer's disease. And I'm not sure who asked before, with the CT brain, sort of that reinforces your suspicion when you see sort of your cerebral atrophies, your enlargement of the ventricles. But again, that can be a normal process in just a normal aging patient in that the ventricles do get larger and there is cerebral atrophy. But you do see sort of some plaque sort of intensities on T2 especially. But it's more sort of about clinically your patient is declining in that mini mental state examinations or other neuropsychological testing. So there are other tests, for example, don't quote me on that, but I think RUDAS and other sort of cognitive tests that can be used to monitor a trend over time for your patient to confirm your suspicion pretty much.
All right, thank you.
Sorry. It's good because we have a small cohort. It's actually better for you to sort of ask some questions so that it best sort of tailored to your own understanding. So it's good that we don't have many numbers this morning. So treatment-wise, so I think about treatment for all dementias based on the cause. So Alzheimer's is a little bit different in that we can do something about it. However, with the other differentials, not a definitive treatment is available. For example, vascular dementia. You sort of manage the patient just as if you're managing a patient with TIA, with stroke. And yeah, with Lewy body dementias, there's nothing sort of definitive as your treatment plan. But for Alzheimer's, because there are a lot of studies going into it, there has been trials of sort of different medications that are used for different stages of Alzheimer's. So I sort of break it down into different stages. So for prevention, so preventing the disease from progressing, usually donepezil is the first-line treatment. Does anyone know what donepezil is in terms of mechanism of action?
It's a ACH inhibitor. ACH esterase inhibitor.
Yeah, very good. Cholinesterase inhibitors. So how it works is that people think that there is a lack of acetylcholine in the synaptic space, in the between the presynaptic and the postsynaptic junction, in that little space if you did neuropharmacology. And basically donepezil is to increase acetylcholine balances, increasing acetylcholine concentration in that space, and that's thought to prevent your progression of disease. Does anyone know what other diseases cholinesterase inhibitors are used in?
I was thinking pyriostigmine for things like myasthenia gravis.
Yeah, very good. Sort of thinking about your neuromuscular junction pathologies. Anything else? The other one is actually Parkinson's disease. So cholinesterase inhibitors are used to augment the acetylcholine and dopamine balances in the brain, and sometimes can be beneficial as secondary or tertiary lines of therapy for more sort of treatment-resistant Parkinson's disease. Anyway, let's go back to treatment. So that's more your mild to moderate disease, your cholinesterase inhibitors, but it actually doesn't modify the disease progression. Rather it's sort of a more prevention of disease early on. However, if you get sort of your moderate to severe disease, it doesn't really change the outcome, if that makes sense, donepezil. So in moderate to severe, you would use Nmda antagonists. And anyone knows why that is the case? So what bounds to Nmda receptors? Glutamate?
Yeah. Oh, sorry. I was just going to say glutamate, but continue. Yeah.
Yeah. So glutamate binds to Nmda receptors, and there's some theory behind there's too much excitatory sort of action potential firing as a result of aberrant glutamate transmission. So the idea about an Nmda receptor antagonist is to sort of decrease the excitatory effects of glutamate, if that makes sense. But that's pretty much it in terms of treatment specific to Alzheimer's disease. However, it is important to know because, as I said, they always hunt impacts. You can have affective disorders such as major depression, such as bipolar disease, such as schizophrenia in people with Alzheimer's disease, or the other way around, in maybe major depressive patients, you can get Alzheimer's disease secondary to the diagnosis. So for these patients, make sure that you're treating not only the Alzheimer's disease, but also you're treating the depression, the agitation, the sleep disorders, the hallucinations, the delusions as well. And one thing else is that provide supportive therapy for patient and family for more holistic care. And that's everything on Alzheimer's disease. Does anyone have any questions?
Is it donepezil specifically that you give to the patients, or is it any cholinesterase inhibitor?
It's mostly donepezil. So different cholinesterase inhibitors has different sort of your blood-brain barrier penetrance levels, and donepezil is usually used because of its CNS penetration to help with that.
All right, thanks.
But again, other pharmacological treatments, like I think neostigmine is also used, but don't quote me on this. Anything else? So vascular dementia. So I think about vascular dementia as if they've had mini strokes or TIAs or probably proper strokes, okay? So I think about it, especially in a patient with stroke or cerebral vascular diseases. And it's actually the second most common type of dementia secondary to Alzheimer's disease. So in terms of history of presenting complaints, you have a stepwise decline in cognitive functioning. And one thing that also sort of differentiates vascular dementia to Alzheimer's dementia, motor-wise, Alzheimer's disease is pretty much spared. However, with vascular disease, sensory and motor deficits, and especially focal neurological signs, can be expected. So sensory and motor deficits. And the risk factors, again, I can think about sort of your dementia mnemonic, but that's more sort of getting a general understanding of the risk factors to causing of all dementias. But with vascular dementia specifically, it's more sort of your same risk factors as your stroke. So same risk factors as stroke /TIA. So those, for example, age, hypertension, diabetes, any cerebrovascular accidents in the past, and sort of your older age male patients who smoke, who are lifelong smokers as well. So those are the risk factors for vascular dementia. So pretty much the same as your stroke. Okay. And if you want to know more about a stroke, Dr. Victor Lean is giving a tutorial on stroke syndromes on the 9th of September. So pop that in your diary, and you can also find it on the website that Alex has put in the chat too. So, criteria for diagnosing vascular dementia is 2 or more of the following. So there is focal neurological signs on examination. Symptoms that are stepwise / abrupt / related to stroke. Third, imaging results. Okay, so imaging results, for example, your CTA, for example, your MRI brain, which shows local areas of infarction. However, this particular sort of imaging is not indicated unless another etiology is to be suspected. Okay, so if a patient shows you abrupt changes in symptoms over time rather than a steady decline, you can think about vascular dementia as opposed to sort of your more progressive dementias such as Alzheimer's disease. And the protocols or the treatment plan or your management of the patient follows how you would treat stroke patients. So antiplatelet, so your dual antiplatelet therapy for secondary preventions. You're treating the cause, for example, high cholesterol, then you're using atorvastatin doses 40 up to 80 milligrams per day. To lower the cholesterol. Again, you would want imaging to confirm sort of your more likely source of emboli if they've had a previous sort of cardioembolic events. If it's atrial fibrillation, that you want to rate control your your AF symptoms. So it all depends on the cause of this specific cerebrovascular accident or any histories of stroke in the past, and you would consult your neurology team for management of their stroke/TIA with your diagnosis of vascular dementia. Any questions on vascular dementia? I'll just put here management, same as. Okay, we move on to frontal temporal dementia. So the first thing I want you to know about frontal temporal dementia is that it is rare. Vascular dementia is probably 10%, Alzheimer's probably 60 to 80, so that leaves you pretty much with 20% of all of the dementias which are sort of from your other causes, your MPH, your frontal temporal dementia, your Lewy body disease, your CJD. And frontal temporal dementia is lower in prevalence. It is similar to an Alzheimer's disease presentation in that it is progressive. And what's more definitive is that you get atrophy of frontal and temporal lobes. Okay. So as a result of that, a classical presentation is disinhibition of patients. So they can have significant changes in behavior and personality. So a classical presentation is that a wife comes in with husband saying that he's been out of the ordinary from who he is. He's changed to a different person, and that the symptoms is progressive. So the wife is complaining how the husband is being worse and worse over time, and that he's changed to another person, more irritable, more sort of reckless, and not considering his words before he's saying them. So that's a classic clinical presentation. And your other symptoms may include speech disturbance. And why is that? Does anyone know?
I can't quite remember. I think it's either Broca's or Wernicke's that's like kind of situated near that area, maybe.
Yeah, actually both is situated in that area because Broca's is frontal, Wernicke's is more temporal. So you're right. So speech disturbance, but more Broca's in your inferior frontal gyrus area, that's causing the speech disturbance. And that's from your severe atrophy of your brain. So if you get little atrophy, for example, in a normal brain with just the aging process, you can get little atrophy of the brain. That does not cause brochophagia. And I'm not saying with frontal temporal dementias, they do develop brochophagia, but there's just some speech disturbances in terms of the expression of words. And occasionally pyramidal signs. Okay. And so diagnosis, again, clinical features with evidence of frontal temporal atrophy seen on MRI or CT. Showing frontal temporal atrophy plus your clinical features. And treatment based on symptoms. Okay, so if they have speech disturbances, referral to speech pathologists. If they have compulsive behaviors, maybe psychotherapy. And extrapyramidal symptoms, you can treat that with sort of your physiotherapy. And if it's getting worse, then sort of doing nerve conduction studies to see whether there is any nerve conduction problems for sort of your more definitive and your more advanced treatment plans. Any questions on frontal temporal dementia?
In general, do you happen to know the cause of frontotemporal dementia, or is it something that we don't really know and just diagnose depending on the clinical features?
Yeah, so I don't think the cause is known. It's more an idiopathic, or basically idiopathic means the cause is unknown. However, it's with aging, there is some study which shows that with frontal temporal dementias, there is a genetic predisposition. And also they are more inclined to have sort of your more affective disorders, for example, schizophrenia, for example, major depression. However, I think the definitive cause is still for investigation. So I'm sorry, I can't answer that.
Yep, well, good. And just with regards to vascular dementia, was that also the case, or is it more just your general atherosclerosis that's more, causing that?
Yeah, vascular dementia, as I said, I think about it pretty much the same as stroke and TIAs. So when you think about stroke and TIAs, that can be caused by a range of different things. You can get it from atherosclerosis, first of all. You can get it from cardioembolism, secondary. And also you can get it from structural diseases. For example, I'm not sure if you're aware, there's something called Moyamoya disease, where there is structural defects of the cerebral blood vessels. You can get it from sort of your patent foramen ovale. Again, embolism caused cerebral vascular accidents. But yeah, I just think about vascular dementias the same as all my other stroke presentations as the cause. And the actually, yeah.
A bit of a stupid question. How would it be different from a stroke then?
Okay, so stroke patients may not have dementia symptoms. So stroke patients may recover, may just be pure sensory or pure motor deficits. They may have focal neurological signs. However, they have nothing cognitively. So on mean mental state examinations, they might score 30 out of 30. And sort of otherwise, they're just pretty much isolated motor or sensory deficits from the stroke itself. Whereas vascular dementia, it's not really like a sudden presentation, just like a stroke. However, it's more from your mini ischemias from your little TIAs that's going off to the brain. leading to ischemia of the small vessels in the brain, and it's usually undetected. The patient doesn't have headaches, doesn't have anything. However, over time, their cognitive function declines stepwisely, and sort of more, and that stepwise is an abrupt change sort of from day to another day, but sort of following that your classic teaching of stepwise presentation, as opposed to a TIA stroke patient comes in with sudden paralysis of the left and the left upper and left lower limb. And in that case, you want them, code stroke, immediate management, whereas your vascular dementia, they can wait. The stroke is not, the mini strokes or the TIAs is not causing them sort of motor and sensory deficits that's severe enough to impact their daily activities of living. In that case, you assess their cognitive ability and you find that consistent with the history, there is a decline in cognition. Then you think about treating their predisposing factors, for example, treating their high cholesterol, treating their high blood pressure, etc. Does that answer your question?
Yeah, that's really great. Thank you.
Yeah. Any other questions? Okay, so normal pressure hydrocephalus. A good acronym, and I think most of you know, is WET, WAC, and wobbly. Anyone know what that means?
So like incontinence, dementia, gait, ataxia. Yeah.
Yeah, very good. So how I think about it is incontinence, gait apraxia, and dementia. But I remember it as the 3 Ws, the clinical triad of MPH. So what other signs would you expect in a patient with MPH?
Also signs of raised intracranial pressure.
Yeah, so you can actually get papilledema. You can actually get your headache that's worse in the morning, that's relieved with cough and vomiting. So with ICP monitoring, which are sometimes placed into the ventricles for patients with suspected MPH, is that you can get spikes of elevated pressure, which can help you with a diagnosis for MPH. And remember the MRI photo that we've seen at the start of this tutorial. So that was an example of MPH with ventricular enlargement as your isolated solitary finding with some sort of your subchronic, your chronic ventricular edema, paraventricular edema that you can see on flare sequence. Okay. Anyone knows the gait you would expect? You get something called a magnetic gait. And again, so people with ventricular enlargement, so high pressure hydrocephalus, they can also get magnetic gait. And the thing to look out for on MRI is actually ventricular enlargement or portion to and sometimes LP is done. They lead to normal pressure. And treatment-wise for MPH, usually LP or continuous lumbar CSF drainage may result in clinical significant improvement in the patients. However, for more definitive treatment, sometimes a ventricular peritoneal shunt or VPS is done to drain that fluid. And that's pretty much it for VPS. So treatment, LP, CSF drainage, or VPS. Okay. Any questions on MPH? You can always ask me later if you do think about any. So last two, we'll talk about CJD and your Lewy body dementia. But first of all, CJD. So remember. So by that, I'm talking about all your sort of your encephalopathies that are characterized by spongy degeneration, neuronal loss, and astrocytosis. Okay, and in CJD specifically, sort of it's caused by a protease-resistant prion protein. So basically, prion proteins are allies with your protease, which degrades the protein. However, in CJD or prion disease, you get that prion that is not degradable by protease, and they deposit and accumulate in the brain, leading to the progressive symptoms. And it's usually a subacute dementia with ataxia. And what's sort of characteristics of CJD? I have ataxia. My patient can have MPH, but what's sort of your more definitive? What's your sort of your pathognomonic sign that you would find on physical examination or general inspection?
Myoclonic jerks.
Yeah, very good. And usually it's weeks to months presentation. And sort of your risk factors is your Kuru population, history of contaminated beef eating, because your prions, sort of your prion disease, or those protease resistance proteins can reside within contaminated sort of your cows, and that can be a method of transmission. Anything else? Your differential diagnosis for CJD. Anyone want to give it a go? So I think about 4 things, whether it's limbic, encephalitis. This is probably more of an extension, but Hashimoto encephalitis. And mitotic encephalopathy. Okay. How do I know if it's Hashimoto encephalopathy?
Can you do like an antibody test for Hashimoto's?
You can, but if it comes negative, can you still have Hashimoto encephalopathy? I guess that's the leading question. The answer is yes. So for more like if you want to make sure, Hashimoto encephalopathy is pretty much another name that another Hashimoto is given to a disease, but basically it's steroid responsive encephalopathies. So if you have an encephalitic picture and you give them steroids and it's steroid responsive, together with your sort of your neuroimaging or your antibody screening tests for encephalopathies, there is a panel. I'm not sure if you're aware, but you can always search up a panel for encephalopathy screening. So there's anti-NMDA encephalopathy. There's a lot of your autoimmune encephalopathies which that the antibody panel can pick up, and Hashimoto encephalopathy, I think, is one of them. And then, but the more definitive or therapeutic diagnosis of Hashimoto is that you give them the steroids and they're suddenly much better. So that's how you differentiate that. Toxic encephalopathy. Does anyone know what patients can get toxic encephalopathy?
Like substance abusers?
Yeah, substance abusers, and what else? I'm looking for a specific population of patients. Remember I talked about how they always hunt in packs. So your psych patients can have encephalopathies, can have dementias. And one of the psych presentation is bipolar. So what do people use in bipolar disease?
Like lithium?
Yeah, so lithium can lead to toxic encephalopathy, okay? So that's one of the side effects to look out for in sort of your lithium administrations.
Yeah. Sorry, this may seem like a peripheral kind of question, but with the, I guess the dementia-like symptoms, would that occur before or like after, say, a nephrotic syndrome induced by lithium?
Sorry, so what was that? I didn't hear you.
I'm just wondering, like, in terms of like a bipolar patient, if you're worried about like the side effects of lithium, would you worry more like as a more pressing concern of the dementia-like symptoms or like the nephrotic syndrome?
Yeah, so toxic encephalopathy is really rare following lithium, but it is one of the considerations. So you're right in that kidney injuries is more common than encephalopathy after administration of lithium. So you do want your UECs, your kidney function tests, sort of as your major panel of investigations once someone is on long-term lithium. But you do want to keep toxic encephalopathy in the back of your mind if a patient do come in with encephalopathy secondary to lithium use.
Cool, thank you.
Sorry. And yes, go on.
Oh, I was just gonna say thank you in case you didn't hear that clear.
Okay, no worries. And okay, so this is probably an extension. On investigation, what else can you see? I'll give you a hint. I'm doing a lumbar puncture.
Talking about investigations for CJD or
Pardon?
toxic encephalopathy.
Sorry, I didn't hear you. What was that?
If you're talking about toxic encephalopathy or CJD investigation?
CJD specific.
Oh, sorry. Is it like the LP with 14-33 proteins or something?
Yeah, so CSF 1433 is a marker that you look for. And on sort of your more advanced screening, and I'm not sure how they do it, you can have tau proteins detected as well, okay? And does anyone know what they signify? So when you have rapid destruction of neurons, you do get CSF 1433. Tau protein is not a sort of a very specific finding as a result of rapid destruction of neurons, but it's more your CSF 1433 that you want to look out for, and that's giving you a signal that the neural cells are being damaged very fast. Okay. So definitive diagnosis, again, just like Alzheimer's disease, you can't really diagnose CJD just clinically. Actually, you can diagnose CJD clinically, but you can't really make a definitive diagnosis of CJD clinically. The definitive diagnosis is from brain biopsy or autopsy, just like your Alzheimer's disease. And on EEG, does anyone know what the EEG finding for CJD is?
Take it bilateral sharp waves on EEG. I don't know if that hurts the.
I don't know the hertz too. I don't know if it's bilateral either. But usually sharp wave complexes that are not compatible with the normal waveform of the EEG in multiple leads, I think from memory is the EEG finding. However, I don't think the EEG is sort of specific enough for you to say, okay, I see that specific waveform and therefore the person has CJD. It's more about the clinical picture, but I think it's certainly a tool that neurologists can use to help with the diagnosis. And treatment-wise, unfortunately, as of the current day, there's no effective treatment, and most patients do die within a year of symptom onset, that is. So once they develop the symptoms, they usually die within a year. So it's a very grim diagnosis. Okay, that's all I have for CJD. Any questions?
Hi, Jason. I'm just wondering, for the CJD, is there much treatment or is it just more palliative?
Yeah, it's more palliative. And also another thing with CJD is that people do want a definitive diagnosis post death. So one of the thing is, if you're suspecting CJD, there needs to be sort of contact precautions. There needs to be special care given at autopsy, just because it's a transmissible disease. From what I'm aware, usually the UniMelb dissection lab for MD1, it used to be you can dissect the brain as well, you know, with your anatomy pracs and stuff. However, with the worry of CJD, I think if you read up on it, there's a bimodal distribution of age in terms of the people who get CJD, and now is probably like another peak sort of during this decade. So they are worried about sort of transmissible CJD in the lab, and that's therefore sort of the dissection of the brain is done before the medical students go in. That's probably going off tangent, probably not answering your question, but yeah, there's no effective treatment, and usually it's palliative care.
Thanks, Jason.
It's all right. So lastly, Lewy body dementia. Again, unclear cause of Lewy body dementia. But once again, echoing theme, progressive cognitive change, get visual hallucinations, you can have PD-like symptoms. And what are some PD-like symptoms?
Like a Parkinsonian gait?
Yes. Anything else? Is there an acronym that you use to remember the Parkinsonian symptoms? So random breath testing is what I use. So rigidity, bradykinesia, and tremor, your resting tremor, okay? If a person says, I have tremor, but that's worse on movement, what is your diagnosis? I'll give you a more sort of comprehensive clinical presentation. 65-year-old man comes in with 15 years of bilateral hand tremors, and his brother has similar symptoms, denies any difficulty of concentration, troubles with ADLs. What is the most likely diagnosis? And how are you going to treat that? Let's pick on some people, shall we? I won't do that to you. So essential tremor, have you guys heard of essential tremor? So usually that's a differential diagnosis to keep into consideration when a patient comes in with tremor. If it's worse on movement, then it's more likely to be essential tremor than Parkinson's disease. And the onset can be very variable, but usually the onset of Parkinson's disease is sort of later on during life. And bilateral tremors is very uncommon in Parkinson's disease. So when you have bilateral tremors, essential tremor is usually the sort of your more likely differential. And you treat your essential tremors with, does anyone know what you treat essential tremors with?
Propanol.
Propanol, what else? You can actually use topiramate as well. Okay. Well, what's topiramate?
Anti-seizure medication.
Yes, but what's the mechanism of action of topiramate?
I have no clue.
Yeah, carbonic anhydrase inhibitors. Okay. Remember from the last tutorial, what else do we use carbonic anhydrase inhibitors in?
Acute angle closure glaucoma.
Yeah, very good. I'm glad you listened. So Lewy body dementias, other than the physical symptoms, Parkinson-like symptoms, you can also get cognitive symptoms, okay? So again, defects in visual spatial processing, your attention deficits, your executive dysfunctions, and your memory losses. So similar presentation to Alzheimer's, but Lewy body dementia is another differential to keep in mind. So I'll just write that down for you. Visual spatial executive dysfunction. And okay, and Lewy body dementia is very common to coexist with your psychiatry symptoms. So your hallucinations, your delusions, your depression, your anxiety disorders can overlap with Lewy body dementias. And diagnosis, again, clinical diagnosis. You want your neuropsychological evaluation, for example, your mini mental state examination, or neuroimaging to exclude any other causes. So frontal temporal dementia can be excluded with MRI brain or CT brain even. And again, treatment-wise, symptomatic treatment, again, no disease-modifying agents are available as of today. So you want to target the symptoms, getting allied health into the care of the patients, psychoeducation of the patients, family support for the carers, and that's pretty much all I can think of. Any questions?
Just with Lewy body dementia, so you said that it presents with Parkinsonian symptoms. Does that mean that it can coexist with Parkinson's at the same time?
I have seen 2 patients with Parkinson's disease who's also got Lewy body dementia, because essentially what Lewy body dementia is that you have cognitive decline as a result of Lewy body accumulation in the brain. And that Lewy body accumulation does occur in Parkinson's disease. I'm not sure if one causes the other. Maybe read up on it and you can let me know next tutorial. But Lewy body is the cause for Parkinson's as well as Lewy body dementia. But I think in answering your questions, I think they can coexist. And I've seen 2, at least myself, on the psych ward that, not on the psych ward, sorry, on the aged care ward, so geriatric ward, at Royal Park who actually does have Parkinson's disease as well as Lewy body dementia. But I think one thing to remember is that memory loss do occur in older patients, and Parkinson's disease is a diagnosis more commonly found in older patients. Older patients do get cognitive decline, and remember how at the start of the tutorial I said they do hunt impacts. So patients with Parkinson's disease can get cognitive decline. So when I saw those patients, what the consultant was sort of deciding between is that whether it's coexisting Lewy body dementia with a separate Parkinson's disease, sort of destruction of substantia nigra, leading to neuronal loss, leading to sort of your typical Parkinsonian gaits, your typical Parkinsonian symptoms, whether that's a separate entity or whether the person just has Parkinson's disease and they're developing memory loss, they're developing cognitive impairment, they're developing attention deficit as a result of maybe major depressive disorders, or sort of your more affective disorders as a result of the Parkinson's disease. So that's what they're deciding between. And I don't think differentiating between one or the other will affect the management plan for that patient. Does that answer your question? It's probably a long-winded way of sort of explaining the idea, but essentially, in short, yes. In long, it's very unclear.
All right. Wait, so just clarifying, this might be a bit of a tangent. So Parkinson's symptoms occur due to the issues with the substantia nigra, but isn't that also the definition of Parkinson's disease?
Yeah, that's the definition of Parkinson's disease. But in Lewy body dementia, you might have a perfectly normal substantia nigra. That's what I'm saying.
Okay, cool. Wait, but then if you have a perfectly normal substantia nigra, how could you get the Parkinson's symptoms?
So Lewy body dementia can occur in other parts of the brain. For example, internal capsule. For example, your head of caudate, your lentiform nucleus. So other pathways along the extrapyramidal path, so sort of following from your motor cortex down through your corona radiata into your internal capsule and down to the decussation of the pyramids, all the way to your spinal cord, but mostly limited to your cranial parts, can have Lewy body deposition, which affect that motor pathway and the fine tuning of that motor pathway. So if you think about all the basal ganglion nucleuses, they can have Lewy body dementias. So it's not as if Lewy body is only attacking the substantia nigra, which happens in Parkinson's disease. Lewy body dementia can be a global deposition of Lewy bodies, which affect overall motor function with Parkinsonian-like symptoms. However, the substantia nigra can be normal, or the substantia nigra can be affected in that deposition process.
Awesome. Thanks so much for that.
No, it's okay. Anything else? So with Lewy body dementia, on autopsy, what you find is that, all right, if we're talking about substantia nigra, this is an extension as well, so you don't have to know this. So there is sort of your destruction of substantia nigra, as we've talked about. However, in Lewy body dementia, we can actually sometimes find your alpha-synuclein or your abnormal clumps of Lewy body actually existing within neurons. Okay, so that's a classical finding. Okay, that's pretty much it that I wanted to tell you about in terms of dementia diagnosis and the differentials to keep in mind. Are there any questions on any of the differentials? If not, we'll finish a bit early today, and I'll see some of you next week. Yeah, so I didn't want to talk about delirium today, but if people want a differentiation between delirium and dementia, I can give it to you now. But usually dementia is more progressive and long-term. Delirium is more sort of your more acute. That's a short way of answering your question, but the long way, if you have a pen and a paper on hand. So how I think about delirium is that, first of all, the attention is impaired, right? Dementia, the person is usually alert and well-oriented. Onset, delirium is acute. Dementia is more progressive, chronic onset. The time course, delirium follows a typical picture of sundowning, and it fluctuates during the day. It can be better with some hours, it can be worse with some hours. And dementia is a very prolonged progressive deterioration. Consciousness is another factor. Delirium, consciousness is impaired. Dementia, consciousness is always intact. And hallucinations can be variable in that delirium patients often have visual or tactile hallucinations. And the typical hallucination that they get is ants crawling or insects crawling in their ward. And with dementia, it can occur in about 30% of the patients, but in very highly advanced diseases. So in your early Alzheimer's disease, you won't get hallucinations. However, in your very advanced Alzheimer's or your advanced frontal temporal degeneration diseases, you can get hallucinations. Prognosis, delirium is better in that it is reversible and you fix the cause. However, dementia, it's largely irreversible, okay? And the stuff that we've talked about, most of them are irreversible and we're just treating the symptoms only. And most of the cases are due to treatable causes, is about sort of 15% of your presentations. So another 85% is usually irreversible in terms of dementia. And delirium, most often it is reversible, so you want to treat the cause. So again, treatment-wise, I think about it differently too. For delirium, I treat the underlying cause, and sometimes to augment that, if they're highly agitated, you can give them some low-dose antipsychotic, okay? So you wouldn't want to give them benzodiazepines, but you can give them antipsychotics. But in saying that, sometimes midazolam, benzodiazepine, is used to dampen down their agitation in the ED. But what's most important about delirium management is establishing sort of a low stimulus environment, your orientation to day and time. So giving them a clock, telling them what time of the day it is, having familiar people in the room so that they're comfortable with their surroundings, and re-establishing their circadian rhythm to sort of reverse that delirium. Whereas for dementia, again, Alzheimer's disease, frontal temporal, CJD, Lewy body, all different management plans, vascular dementias, all different management plans, but you want to establish a diagnosis, first of all for prognosis, but second of all, if it's Alzheimer's disease, then you can maybe initiate cholinesterase inhibitors. And sometimes, if, for example, more advanced diseases, when you do have hallucinations, when you do have agitations, when you do have your more sort of your psych presentations coexisting, then you would consider maybe a low-dose antipsychotic to augment their behavioral symptoms. That's how I think about, generally as a spiel, the difference between delirium and dementia. Does that answer your question?
Yes, it does. Thank you.
No, it's all right.
Jason, I just have a quick question about, like, this is unrelated to today's lecture, but just with the recordings, do you know where I can find the previous stuff from your tutorials?
Yeah, it's on our website. If you click under medicine tutorials, I think only 2 of the recordings are actually uploaded. I don't think there's any problems with the recordings. However, I think there's just some delay with uploading them, but you can find it on the website. If you go under the, what do you call it? Is it the medicine program lectures? I think medicine revision lectures.
Yeah, I was on that website and yeah, I just couldn't find it, so I was confused.
Okay, Alex, would you mind actually?
Yeah. So there is a bit of delay because it requires, like, the whole Zoom recording, then the conversion, and then a little bit of editing, and then trying to upload it within a timely manner. And we do try to get these recordings up as much as possible, but they will be uploaded soon, and there's nothing wrong with regards to the whole recording and tweaking and editing process. So just bear with us. Sorry for the delay, but they will be uploaded soon. Don't worry.
Oh yeah, no worries. Thanks, guys. I was just wondering if it was going to be uploaded, but
No,
thanks.
all good.
Yeah.
And it is encouraged, although the recording is available, to sort of attend the live one, because obviously you can tell today that there is a lot of questions that's being asked, and I think it's just better for your learning process as well.
Actually, on that note, also not specifically for today, but I think for the virtual ward rounds, they had some slides. Are those generally uploaded to the website?
No, they're not. So I think it's just the video recording. Yeah.
Okay, and if we wanted access to those slides, would it be better off contacting the lecturer?
So I don't think Victor is happy to sort of distribute the slides, just because first of all, there are some clinical information on there, although it's de-identified. However, I think it's just for future references, and for distribution educational purposes. He will probably want to keep the slides to himself, and for teaching for impact ourselves specifically, rather than distributing it out. But the recording is sort of available, and I'm pretty sure you can watch the recording so that you can maybe get a screenshot of the slide. That's an option. But let me just discuss with Victor to see what he thinks about distributing the slides. But if he does decide to distribute, it will be available on the website rather than sort of sending it to individual people.
Yeah, that's all great. I think it was mainly because there was a bit of a problem with the quality, I think, over Zoom. So a lot of it was a bit blurry on the actual recording. But
Right.
yeah, all good. Thanks.
Yep, no worries. I'll bring that up with him, and I'll see how he thinks, and then maybe I can update you next week.
Yep, that's great. Thanks.
Hey, Jason, I had another question. I was wondering if you can go through the T1, T2 MRIs and also the T1 with flare.
Oh,
again.
yes, please.
Yeah. Okay. So
Yes.
so this is pretty much another whole tutorial, but essentially, what the difference is that T2 is showing hyper intense. Actually, I'll bring the picture up. Okay, so here, this is a T2 flare. And the reason why I know this is because I look at the gray matter. Okay, I look at the gray matter and the white matter. So in T2, the white matter should be black, and the gray matter is probably more white. Can you see that, Ray?
Yep, I can. So,
Yeah.
repeating what you
So just the differentiation between the two. T1, I expect brighter white matter compared to gray matter. But if you see that's flipped, it's telling you it's T2. Okay, then I look about with the CSF. I know because it's a T2, I would expect the CSF to be bright. However, in this case, it's black. Now that's telling me the CSF has been attenuated, or rather the signal of the CSF is attenuated. And that tells me it's a flare sequence.
Mm.
Does that make sense?
Yeah, that makes sense. So for T2s, you mentioned that the grey matter was white and the white matter was a bit darker.
Yeah, so just don't remember that. How I think about it is T1, grey is grey on T1, white is white on T1. However, that's flipped in T2. I think that's easier to remember than remembering what's black, what's white.
Too easy. All right, thank you.
But again, I don't think radiology is taught very well. I think this is probably a summary of about 10 pages of information, like what I'm telling you now, in probably like 1 minute. I think that's probably very useful just for your interpretation to get a sense of what slide you're looking at.
Absolutely, I agree. Thank you.
It's all right. And I think Alex has put a link on the website. Okay, if no further questions, go and enjoy your Saturday afternoon. And thanks for coming today. I really like the engagement. I think it's very useful. And yeah, if anything that I'm saying that you think is incorrect, feel free to message me and update me, because a lot of these stuff is sort of my own notes from MD1, so it can be a little bit outdated, and I know some hospitals do go with different guidelines in terms of management too, so feel free to educate me too. Yeah, and I'll see you all maybe next week if you can make the tutorial.